Hello, my name is Erin Avers, and I am a second-year medical student at Lake Erie College of Osteopathic Medicine in Bradenton, Florida. I would first like to thank you for this opportunity to present this valuable case report. Our patient is a 64-year-old Hispanic female presenting for her initial evaluation in a medical weight loss program. Her past medical history was significant for obesity and hypertension. She had recent labs that revealed elevated triglycerides and an A1C count consistent with prediabetes. Thorough review of systems revealed dyspnea and palpitations. She admitted that the symptoms had been present for most of her life, and she had always attributed them to being obese as well as having a lack of physical conditioning. Family history on her mother's side was significant for multiple cardiovascular events and possible sudden cardiac death in multiple family members. Of note, her mother suffers of congestive heart failure. Physical exam showed a 2 out of 6 systolic ejection murmur. The murmur increased in intensity during the Valsalva maneuver as well as when the patient went from seated to standing. The murmur decreased during hand grip and squatting. When asked if she had ever been told she had a murmur, the patient did state that a clinician at an urgent care about 5 years prior had mentioned the murmur. However, at the time, a further workup was not recommended. These findings, including the physical exam as well as review of systems, prompted her for referral for echocardiogram, which revealed asymmetric hypertrophy of the left ventricle, as well as systolic anterior motion of the anterior mitral valve. The report confirmed the diagnosis of hypertrophic obstructive cardiomyopathy, or HOCM. Metoprolol 25 milligrams was then added to her regimen, and the patient was referred to a local cardiologist. Cardiology obtained a Holter monitor that revealed multiple bouts of supraventricular tachycardia. The patient was then referred to a well-renowned institution for electrophysiology and further treatment. HOCM is a significant cause of sudden cardiac death, especially in young athletes. It most commonly presents during the second and third decades of life, making this case an exception. It is genetically inherited and affects the sarcomere proteins involved in myocyte contraction. The patient did note significant family history of cardiovascular disease. Most often, the condition is asymptomatic, but among those who do have symptoms, dyspnea is most common, which this patient did admit to having. Given that symptoms are worsened by exertion, the patient's weight loss regimen was drastically modified. Rather than high-intensity exercise, the patient was instructed to participate in minimal, light physical activity. Semaglutide subcutaneous injection was prescribed weekly due to its safety and efficacy, especially in those with comorbid conditions. This case has valuable takeaways that we would like to highlight. Had the patient not had her murmur worked up, she could have been prescribed potentially fatal exercise routines and contraindicated medications. We like to highlight from this case the importance of a thorough history and physical to create an individualized weight loss regimen for all new patients. This case also allows us to discuss the benefits of newer generation weight loss medications like GLP-1 agonists for patients with underlying cardiovascular disease. Semaglutide was especially useful in this scenario due to its ability to lower blood pressure, triglycerides, and glucose. Older generation drugs, such as stimulants, can have adverse effects to increase blood pressure and heart rate, which could have been harmful to this patient. In conclusion, this case offers us a chance to reflect upon the necessity of a comprehensive history and physical exam prior to beginning a medical weight loss regimen. With the comorbidity of cardiovascular disease and obesity, lack of attention to potential risk factors may be detrimental to a patient. This case also exemplifies a unique presentation of a genetically inherited condition and offers insight for suspecting HOCM in an older patient. Thank you so much for listening and for this opportunity to present a valuable case.